Good afternoon. Welcome to today's Internal Medicine Grand Rounds. There is no commercial support. Our speakers and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity, and if you're viewing online, we'll list that link in the chat section. And if you're viewing after the fact, you can find your evaluation link in the description section of the video. If you have a question, please enter it in the Q&A chat if you're viewing online, and then we'll ask questions from the audience after the presentation is over. It is my pleasure to introduce Dr. Swathi Kanakamedala. She is a third-year internal medicine resident at Northeast Georgia Medical Center. She grew up in Pennsylvania and attended medical school at Virginia College of Osteopathic Medicine. She is pursuing a career in hematology and oncology and will complete her fellowship training at the University of Florida. Join me in welcoming Dr. K.
Thank you, everyone, for being here today, and good afternoon. Today, I will be talking about the emergence of artificial intelligence in oncology, current and future perspectives. I have no financial disclosures. Here is our learning objectives for today. We will define what artificial intelligence is, differentiate the two different subsets of AI-based models, recognize the utility of AI in different areas of cancer care, and then also identify the challenges associated with AI in oncology, and also discuss the future role and perspective of AI in oncology as well. So this is our agenda for today. First, we will spend some time kind of understanding what exactly is artificial intelligence and how it works. Then we will go into how AI is used in the cancer screening and detection, how it's used in diagnosis and staging, the research that has been done looking at AI in precision medicine, some challenges associated with this, the future perspectives, and then we'll conclude our presentation. So I'm sure all of you guys have heard of AI in one way or another, but what exactly is AI and where did it originate from? It originated in 1956 by a professor by the name of John McCarthy, and he created a summer workshop at Dartmouth College where he was trying to bring together scientists and researchers to help develop ideas and talk about strategies for developing these thinking machines. So for that summer workshop, he came up with the term of artificial intelligence for that project. Since then, that conference has been widely considered the founding time when AI was considered a field of research. The definition that we most understand, in short, is the science of making machines that think like humans. But an official definition of AI is a program machine that can learn and recognize patterns and relationships to help make an output from those predictions. There are two main subsets of AI. There is machine learning, and then there's another subset called deep learning, and we'll talk a little bit more about each of those. So machine learning is a subset of AI, and it's one of the ways we can use it. It is the ability of computers to learn without explicitly being programmed. Now, it starts off with data. You give the model, it could numbers, it could be photos or text, and then all of that data is gathered and then used as training data for the model itself. Then the more data you give this program, the better the results. The model will then train itself to make final patterns or predictions. And there's three main functions for AI. For the ML models. One is it can be descriptive, where the model is using the data to explain what happened, or it can be predictive, where the model uses the data to tell you what will happen, or it can be prescriptive, where the model suggests what action to take next. The common examples that we know nowadays is language translation, like Netflix suggestions and our Google search. Now we'll talk about deep learning, which is a subset of machine learning itself. And these are the models that are used most often in cancer research and other medical research as well. Think of deep learning as your own neural network and like neurons in our own brain. And they also coined the same term as artificial neural networks, or ANNs, or convolutional neural networks, or CNNs. And each of these neural networks consists of multiple layers, and all of those layers help analyze the data and then generate an output. Now, each of these layers, as you can see in the highlighted figure, can have a different function. So for example, in image recognition, one layer can be dedicated to identifying different features of a face. For example, one is in charge of looking for eyes, the other layer looks for a nose, or the other layer looks for a mouth. And then another layer can be used to help incorporate all that data together to tell you whether these features indicate a face, yes or no. Similarly, in oncology, for example, one layer can be used to look at the detection size of the lesion, or it can look at the classification of the lesion, or it can tell you the characteristics of the lesion itself. So that's another area where deep learning models are being incorporated. Our common other examples that we have of deep learning models are your automatic vehicles, language recognition, facial recognition, like I talked about, and ChatGPT. In these models, the more layers you have, the more potential you have to make and do more complex things. So a lot of researchers have the goal to incorporate multiple layers in their model so that you can get a better output. Now, this table is highlighting about 15 current FDA-approved AI devices that we have in oncology right now. And this was done between the years 2016 all the way to 2020. And some of them have been used to detect lung nodules, breast lesions. Some have been used for lung cancer diagnosis, liver diagnosis. But these are just some of the current FDA-approved ones that we do have. And these were done over the last 5 to 10 years. Now we'll look into how AI is being incorporated into oncology. There's different aspects of oncology, and AI was studied in those areas. And one of them is precision medicine, where AI is looking to determine patient prognosis, response to treatment, such as immunotherapy or targeted therapy. Another field of research is cancer diagnosis, using AI models to help detect early cancer, diagnose cancer, and classify it. And another area is cancer research, where AI devices are being studied in targeted discovery, optimizing clinical trials and recruitment. And another very common field is radiotherapy, where AI is used to help radiologists in those fields. On the right side in figure 4, on the very top, is bar graph. And this is representing the total number of publications that we currently have of AI in oncology. And you can see by the red bar graph that this is highlighting that most of the publications and research has been studied in cancer diagnosis itself. There still needs to be a lot more research in the other 3 areas like precision medicine, radiotherapy, and cancer research. In the figure at the bottom right, this is highlighting a breakdown of the different cancer types by different percentages. And most of the publications looked at breast cancer, lung cancer, brain cancer, and about 15% were other types of cancers. So we all know that early screening helps decrease the mortality for patients, especially when it comes to our most common types of cancers, including cervical cancer, lung cancer, and colorectal cancer. So we'll talk about how AI is being used in these 3 areas and go from there. So first, we'll start off with cervical cancer screening. The USPSTF guidelines recommend screening women between the age of 21 to 29 every 3 years with your traditional cervical cytology alone. And then once they turn 30 up to age 65, we test every 5 years with HPV testing alone, or you can do HPV plus cervical cytology co-testing. Now, when the cytology comes back positive, only a subset of these HPV positive women actually undergo further evaluation and referrals for colposcopy. So that is triage based on the HPV genotyping and the Pap cytology itself. However, there are challenges with that because there's limited sensitivity and reproducibility of that cytology, and that's mainly due to quality control procedures and frequent retesting that is required for those cytologies. So one of the goals that researchers are looking at is to see how AI can be used in this area to help improve the efficiency of cervical cancer screening. So Wen Sensen in 2020 came out with an article that looked at an alternative triage strategy that uses dual stain cytology rather than your traditional manual reading of a pap smear cytology. Now, in figure 5, you can see that the red nucleus A is representing positive staining for the Ki67, and then the brown staining is positive for the P16 staining. The presence of both of these markers in the same exact cell has been linked to cervical carcinogenesis and specific HPV oncoproteins, such as E7. So currently, the AI models that are being used are to help the lab techs meet the accuracy of the manual reading, but no AI model has yet been looked at to improve patient outcomes. So these authors in this article wanted to create an AI model that uses dual staining instead of your manual pap smear cytology to see if they can help improve the reproducibility and efficiency of cervical cancer screening. So their AI model was called CytoReader, and again, it was focused on the dual stain cytology, and it uses 2 deep learning models. One of them was called Convolutional Neural Network 4, and that's because it had 4 layers. And then the other one is Inception V3 with 48 layers, or INC-V3. These models were each trained on training slides to make sure that they were accurate, and a slide was considered positive if there was at least 3 or more dual stain positive cells for the CNN4 model, or at least 2 for the INC-V3 model. Then they used 2 different population sets. One was a biopsy study set, which was women between the age 18 and plus, and these were from the University of Oklahoma Health Sciences Center between the years of 2009 to 2011. And then their second population set was the Anal Cancer Screening Study, or ACSS, which was based on HPV women who were 25 plus between the years of 2012 to 2015, and that was from Kaiser, Northern California. In total, they analyzed 4,253 slides. So once they generated those models, the cytology was then classified based on the Bethesda system, which we are familiar with, and that it goes from either negative for malignancy or ASCUS, like atypical squamous cells of undetermined significance, or low-grade squamous cell or high-grade squamous intraepithelial lesions. Then the final diagnosis was classified based on the cervical intraepithelial lesions, a neoplasia scale or CIN scale, and that ranged from either no indication for biopsy all the way to CIN3, and beyond that would be invasive cancer. The anal disease was classified based on the AIN scale as well. The primary endpoint for the biopsy study set was either CIN3 and over, and for the ACSS group, it was AIN and 2+. So the table is showing the results of the study that they did, and I want you to first look at the first 2 rows. Oops, hold on. Okay. So here in this first row, it's the manual readers. The second row is the CNN4 readers model, and you can see that when we were looking at just the positivity rate, the AI model had fewer positivity of 57.9% compared to the manual readers who had 63%. However, it was at equal sensitivity, but at higher specificity. So 45.6% higher specificity in the AI model group versus 40% in the manual readers. Similarly, in the ACSS validation set, you could see the same findings. There was a lower positivity rate for the CNN model, which was only 63% versus 71% in the manual set. Similarly, the sensitivity was the same at 92%, but the AI model did demonstrate a higher specificity of 46% compared to the control group, which was 36%. So the other findings that they found was that the AI model did reduce the number of unnecessary colposcopies by 1/3 compared to your traditional pap smears. And that was 42% versus 60%. The other finding that they found was that there was similar performance in the AI model versus the manual readers in diagnosing high-grade CIN, which requires immediate treatment. So now we'll talk about colon cancer screening. The current USPSTF guidelines recommend that we screen adults between the age 45 to 75, and that can be done by different screening modalities, either by your high sensitivity FOBT or the FIT every year, or the DNA FIT every 1 to 3 years, CT colonography every 5 years, flex sigmoidoscopy every 5 years, or the flex sigmoidoscopy every 10 years, plus the FIT every year, and then your traditional colonoscopy screening every 5 to 10 years. Our gold standard for colorectal cancer screening is, however, the colonoscopy. So a lot of research is being done involving AI models in this setting. Research has shown that 1% increase in your adenoma detection rate, or ADR, is associated with a 3% decrease in the risk of colorectal cancer. So this highlights the importance of achieving a high ADR with these screening modalities so that you can reduce the risk for patients in the long run. Unfortunately, there are reported miss rates of up to 27%, and that is often due to polyp characteristics and operator use as well. So some researchers have been generating automated polyp detection systems that can help assist endoscopists to help improve the accuracy of colon cancer screening. So one article by Wang in 2019 looked at a non-blinded prospective randomized controlled trial. They looked at 1,058 patients, and they looked at your standard colonoscopy versus AI-assisted colonoscopy. And they wanted to see what the impact of an AI compared to a traditional endoscopist was on the polyp detection rate and the adenoma detection rate. So in the figure on the bottom, you have to start from the left to the right. And then, this is the deep learning model that they created. You first give the model input, which is a colonoscopy image, and then that is warped into a binary image, 1 being polyp and 0 being no polyp. And then it generates a probability map, and then the output will show the tracing boxes highlighting the polyps themselves. This algorithm itself was validated, and it was found to have a per image sensitivity of 94% and specificity of 95%. And the system processed at least 25 frames per second with only a delay of 76 milliseconds. And they found that that delay was hardly noticeable to the endoscopist. When they did do this trial, they did have the system monitor right adjacent to the original endoscopist monitor, and they did compared it in real time. Now, this slide is highlighting the results of their study. So in the table below, you can see we're looking at your polyp detection rate, adenoma detection rate, and then the mean number of detected polyps and adenomas. Then we're comparing your routine colonoscopy versus your AI colonoscopy or AI-assisted colonoscopy. And what they found was that there was significantly a higher number of polyps and adenomas detected by the AI group versus the control. In addition, there was increased rates in the ADR and PDR when using an automated system. They did find that there was no difference in finding and identifying larger adenomas, which are the ones we don't often miss. And then they did also find that the AI model had better performance in diagnosing the higher number of hyperplastic polyps as well. So in conclusion, their results did show that having an automated detection system that assists endoscopists can definitely increase the adenoma detection rates, therefore decreasing the risk of colorectal cancer in patients. Now we'll talk about lung cancer screening. So the USPSTF guidelines recommend screening adults between the age of 50 to 80 with low-dose CT scan who have a 20-pack year smoking history or more and currently smoke or quit within the last 15 years. However, lung cancer screening remains to be one of the lower screening rates nationwide, and there are challenges and barriers associated with this. One of the barriers is low adherence. Another challenge is the high false positive rates and the complexity of analyzing and interpreting all these CT scans. In the figure to your right, this is highlighting the use of AI in different areas of lung cancer screening. One of them is in screening eligibility, another is in radiation dose reduction, another area is in lung nodule detection and classification, and another area is determining your optimal screening intervals. So there was an article in 2019 that showed by Accreditation that was working on a AI model that helped utilize a patient's current CT scan results and compare it to prior CT scan results to help predict the risk of lung cancer. So they analyzed 6,716 cases from the National Lung Cancer Screening Trial, and their results showed that when the previous CT scans were not available, the AI did outperform the 6 radiologists with an absolute reduction of 11% in false positives and 5% in false negatives. However, when the prior CT scan was available, they found that the AI performed just as similarly as those 6 radiologists. But overall, the AI model did increase the accuracy and the consistency of lung cancer screening. Now, some of us are probably familiar with circulating tumor DNA, but it's another newer emerging field for detecting cancer early. Just to explain a little bit about what it is, the idea is that we have tumor cells in our body that are not currently visible to the eye, but when these tumor cells die, they shed the DNA into our bloodstream. And so you can take a liquid biopsy, which is just a blood sample, and then you detect it for the circulating tumor DNA that could be specific to different types of cancers. So now the question becomes, can we generate an AI model that does that for you and analyzes that information and tells you what the cancer types are? So this is an emerging field, like I said, and there still needs to be a little more research in this area. But one article in 2018 by Cohen made a machine learning model. It was not a DL model, called CancerSeek, and they used the model to help detect and predict 8 cancer types using ctDNA. And the AI model was focused on analyzing 16 gene mutations and 8 proteins. The accuracy did range quite a bit. It was 39% all the way to 84%. And the limitation with that study was it was only limited to your traditional machine learning algorithm, meaning that you have to give that data and train that data. The machine is not able to make complex interpretations unless you give it the data. So now we'll talk about how AI is being used in cancer diagnosis and classification. So the idea is, what if you can generate an AI model that takes the histopathology, the radiographic data, the endoscopic images, and puts all of that together for you and tells you what the type of cancer it is. So that's the field that this is looking at, and we'll talk more about it specifically involving skin cancer. Our current way we diagnose skin cancer is that you do a clinical screen, and then if you find a suspicious skin lesion, you do a microscopic analysis, which leads to a biopsy, and then you do histopathology on that biopsy results, and then you finally get your diagnosis. So authors and researchers have been looking to see if they can generate an AI model that does that process for you and helps classify the skin lesions. One of the very first deep learning model that came out was in 2017 by Esteva, and they looked at skin cancer detection specifically. They looked at 129,540 images of the skin, and they tested it against 21 expert dermatologists, and their objective was classify and differentiate between carcinoma versus benign seborrheic keratosis and melanoma versus benign nevi. And their results showed that AI was just as effective as dermatologists. A more recent article by Marone used a AI model called ResNet 50, and they looked at the sensitivity and specificity of 112 German dermatologists to a single CNN or deep learning model to help detect the most common skin cancer lesions. And they had 5 categories. So your first one was melanoma, the second one was nevus, the third category was just basal cell carcinoma, and then your fourth category was actinic keratosis and squamous cell carcinoma, and the fifth category was seborrheic keratosis, lentigo ciliaris, or lichen planus. So this table is showing the comparison of dermatologists versus the AI model at equal sensitivity for each of the classes. So this is highlighting that if overall the AI model had higher specificity of 94% and above, all the way up to 99%, compared to dermatologists, which range from 79% to max 97%. But most notably in the melanoma group, the AI model had a higher specificity rate of 94% compared to the dermatologist alone, who had it at 79%. So this did show that an AI model can be used or help in the process of detecting cancers and at a higher specificity rate. Now we'll talk about how AI is used in precision medicine. But what is precision medicine? These are basically your individualized treatment plans. And oftentimes precision medicine can be classified into either disease prognosis or a patient's response to treatment. So the goal would be to first provide interventions to patients who benefit the most, and then avoid in those who have higher risk versus benefits. So some researchers have looked at generating these deep learning algorithms that will help make these predictions about tumor relapse or even a patient's response to treatment. This is, again, like we talked about earlier in the presentation, one of the areas in oncology and research that there aren't a whole lot of publications in this field yet. However, I did find one that did talk about deep learning models and immunotherapy. And the idea behind it is that not all cancer patients respond equally to immunotherapy. And the current way that we predict their response is based on biomarkers like your PD-L1, TMB, and MSI. And these have to be obtained by biopsy. So there are some limitations with that. Biopsy is invasive, it's limited to a single tumor region, and there's limited predictive value with it. So researchers are working on generating AI models that will help predict patient biomarkers and tell you the response or predict a response that patients can have to immunotherapy. One study by Johannet looked at an AI model that combined the clinical data plus the histology to predict a patient's response to immunotherapy in advanced melanoma. And they found that the model accurately classified patients into responders versus non-responders. So now we'll talk a little bit about the challenges and the future goals of AI in oncology. Although there is a lot of potential with these AI devices and AI models, there are still a lot of challenges and limitations associated with it. All these studies have been done in the research setting. None have been implemented in a real-world application. Main reason is because in order to do a research study in the real-world setting, you have to have a large, diverse data set that comes from medical centers. And oftentimes medical centers are hesitant to provide this data to these research organizations. So there will have to be more and more studies and research done, and also guidelines and guardrails to help determine how do we give this data safely, and so that we're protecting patients' rights, confidentiality, and also protecting the outcomes that we are expecting. One major challenge associated with AI is your black box, is what they consider it as. But this means it's difficult to understand how the AI models are generating the outputs. And this is mainly due to the multiple layers that are involved and the different parameters that are used. Another concern is that this is data. So data is vulnerable to breaches, hacks, and attacks. So there would have to be some sort of regulations put in place to ensure that all this data that's being provided is, again, properly taken care of and not misused. However, AI does have potential in oncology, and not only is it being studied in oncology, it's being studied in other fields of medicine as well. And I anticipate that in the next 5 to 10 years that there will be more studies done, but we do need to address the challenges associated with it as well. That concludes my presentation, and these are my references. Does anyone have any questions?
We have a question down here.
Thank you. That was a really fascinating topic. So based on, I mean, this might be like a difficult question to answer, but based on what you've seen and, looking into this topic, what is your prediction about the future? Like, what is the role of AI in the future, like 10, 20 years down the line, in oncology or in other fields? I mean, do you think that it's gonna, like it's gonna take over physicians' jobs? Do you think it's going to be the way of the future, or do you think it's going to be a fleeting thing that they're looking into right now? So yeah, I would appreciate that.
Yeah, so I think that is one of the concerns that a lot of physicians have is if AI will take over a physician's job. However, these are devices that are meant to be used as tools. So for example, outside of oncology, what I've been learning is that AI can be used with EMR or your documentation, note-taking. It could be used as a tool to help improve burnout rates or improve efficiency. So I see that AI will be solely incorporated into our healthcare system to help as an assistive tool, but it can't replace the clinical decision or the final decision that is made between a physician and a patient. In addition, especially in oncology, the patient-physician relationship is so valuable that there still has to be an open conversation between a physician and the patient to come up with the final treatment plan or decision. And the AI models are just as good as how they're made. So an AI model has to be validated, has to be accurate. So if physicians have to be able to understand how to interpret these models, they can't just rely on them solely.
Thank you, Swathi. That was a very well done presentation, both the presentation itself and how you presented it. And I appreciate the kind of definitions and breakdown. This is a new and emerging field. And kind of just to add on to Hasni's question, are you seeing any of this implemented currently? Or I guess, how soon do you see it implemented? And yeah, I would like to think, same as you, that this will kind of enhance our ability to promote positive patient outcomes without replacing the need for the human touch and the actual physician.
Mm-hmm. Yeah, and so I think it will probably in the next, all this research was done in the last 5 to 10 years or so. So I anticipate that in the next decade, things would get a little bit more, we'll get more and more research about how these AI models can be used. But a lot of this research was done, again, in the research setting. There hasn't been any real-world application of these studies that I mentioned, other than the AI devices that the FDA approved earlier. So those were all mostly in the radiotherapy section, like area of medicine. But the other AI models that I talked about have not been implemented in clinical setting. So we would still have to see how this translates into our clinical practice.
Hi, very nice presentation. My question was this, that if you are saying that some AI model has a sensitivity of, let's say, 97%, and the clinicians have a sensitivity of 98%, let's say, but what we are comparing that sensitivity to, like what's the baseline diagnosis establishing criteria, right? Because if we are saying the model is predicting at 97% and clinician is at 98%, let's say, but what's the final diagnosis, like the final judgment, that patient truly have the disease or does not have the disease?
Yeah, so all this data already has the final answer to it for these AI models. It's either you have the disease or you don't have the disease. So the data that is provided, so for example, when they were looking at skin cancer lesion detection, they provided images of skin lesions. Same images, it was like a set of, let's say 40 to 50 skin lesion pictures. The dermatologist will sit there and answer a series of questions regarding those images, and the AI model would do the same thing. But the sensitivity and specificity are based off of those, and so the results are already based on a image which was already having a diagnosis of whether it had the disease or not. Does that answer your question?
Have you, in your readings on this, come into contact on anything of hospitals implementing some of these AI systems?
So in other countries, it is being looked into, using it mainly in the electronic medical record system, where some small hospitals are deploying these AI models to see if it can help improve like the efficiency and decrease the time it takes to write notes, for example. But I'm not aware of anything that's currently being done in our country regarding that.
Any more questions? We do have a comment online in the chat. So I'd like to share this comment from Angie Caton, who's online, and she says that it has been a privilege to work alongside Dr. Kanakamedala on several impactful oncology quality improvement projects and screening projects during her residency. She has made a difference in our community, and I know that she will make the best oncologist ever. Okay, thank you so much for your presentation.